Good afternoon and welcome to ASE's Coding Webinar. Today's webinar is titled 2014 Update, the latest changes to cardiovascular ultrasound and its impact to you. The purpose of the webinar is to provide a better understanding of the latest changes to cardiovascular ultrasound reimbursement and assist with a correct billing to receive the payments earned. Before we get started, I have just a few housekeeping items that I would like to go over with you. First, we do encourage you to download a copy of the PDF of the PowerPoint slides associated with this presentation found in the resource section of this player. Next, since this is a live webinar, you do have the opportunity to have your questions answered by the speaker. To ask the speakers a question, click on the question mark icon in the left-hand toolbar and type and submit your question. You may do this at any point during the presentation. Questions, however, will be answered at the end of the presentation. We will do our best to ensure that all questions are answered. However, this may not be possible depending on the number of questions presented. We now also have a help tab to the right of the chat. If anyone is having any technical issues, they can click on the tab to submit a ticket as well as look over some other useful information such as frequently asked questions, tech support number, etc. To complete your evaluation for this event, you must be logged on for the full event. At the end of the session, you will be automatically redirected to a new page. Once there, find the name of the session and click on the evaluation link. Complete the evaluation so that can be submitted to ASE. Without any further delay, let me introduce you to our today's speakers, Diane Millman and Judy Rosenbloom. Diane Millman is based out of Washington, D.C., with Powers, Powell, Sutter, and Burville attorneys at law. Her areas of expertise are health policy, reimbursement, fraud and abuse, and provider and practitioner operations. In recent years, she has focused primarily on the representation of physicians, ambulatory care providers, and professional and trade associations. Diane has represented ASE for over 25 years and was named one of Best Lawyers in America in 2011 in the field of healthcare law. Judy Rosenbloom is the founder and president of JR Associates, Inc., a reimbursement consulting practice that helps healthcare providers, medical device manufacturers, investors, and other healthcare organizations find proven practical solutions to highly complex coding, coverage, and payment challenges. For more than 2 decades, the firm has provided comprehensive services to some of the most innovative companies in the life sciences industry. Under Judy's leadership, JR Associates has built a reputation for delivering reimbursement assessments and strategy execution with relevant practical solutions. Judy's perspective is shaped by extensive experience, both as a registered adult and pediatric cardiac sonographer and as an entrepreneur who built a successful cardiovascular and diagnostic imaging services business. Diane, I will now turn the presentation over to you.
Thank you very much. Why don't we just proceed with the slides? I'll just run through the introductory ones. As has been indicated, we are here to talk about payment issues affecting cardiovascular ultrasound, and so let's get started. My presentation will focus on Washington-related developments and especially healthcare policy developments both on the Hill and at the agencies that affect cardiovascular ultrasound payment. And we're going to focus on Medicare payment, basically because private payers' payment situations vary from one payer to the other. And while there have been some trends, in general, we're going to be focusing on Medicare, which tends to be a bellwether for private payers. So, where are we? Medicare payment reductions have been in place and have been accelerating for office-based echo, actually up until 2014. That's because the PPIS survey data, which was not good to cardiology, that was practice expense survey data that the AMA collected, has been phased in for a number of years. This year, however, we have seen the respite in the decline in payment for cardiovascular ultrasound, or at least for echocardiography. There has been an increase based on some changes in the direct costs that are taken into consideration in determining Medicare payment rates, and especially the echo loom. Many cardiology practices, however, have already been acquired by hospitals as a result of payment changes affecting both echocardiography and nuclear cardiology, and our word is that there are many more that are in process. This chart illustrates why there has been a very substantial payment reduction since 2006 as a result of the implementation of new practice expense data, that is the PPIS, as well as the consolidation of spectral and color Doppler codes into the primary echocardiography code. This year, as you see, there is a bump up in the global payment for echocardiography, and that is a bump up really in the technical component for echocardiography services provided in office settings. Professional component payment has remained relatively steady over the years. So where are we going? We have a number of trends that we need to take into consideration as we consider that question. First, there's the impact of the ACA on hospital finances generally. As most of you probably know, hospitals were among the major payers or the major financers of the ACA. Many of those, the cost of that healthcare reform came from the hides of hospitals, both in the form of reductions in payment for disproportionate share and direct and indirect medical education. Second, we have level playing field potential legislation, that is legislation that would make a hospital outpatient payment for what amounts to the technical component of echocardiography equal to what it is in physician's office settings. Third, we have physician self-referral legislation that is under active consideration in Congress, and that would eliminate the ability of physician practices to provide advanced imaging services. That doesn't include echocardiography, actually. The legislation currently under consideration does not affect echo, but it could serve as a precedent for eliminating physician office echo as well. Next, we have appropriate use criteria and pre-approval provisions that are under consideration as part of a SGR reform and replace bill, and hospital outpatient bundling, which is taking place at a number of levels, both congressional and regulatory. Finally, we have a number of other physician fee schedule challenges. So let's consider the position that the ACA has placed hospitals in. Unfortunately, as I indicated, the ACA actually is funded on the backs of Medicare to a very large extent, on the backs of hospitals. Almost half of the funding for healthcare reform came from cuts to Medicare and Medicaid payments, and a lot of those cuts were hospital cuts. The hospitals, as a result, are in financial straits, especially in those states that have decided not to expand their Medicaid program. The cuts will be very substantial, especially for disproportionate share and underinsured folks, that is mainly inner-city teaching hospitals. As a result, there's likely to be less capital available for maintenance and replacement, and fewer dollars available for recruitment and retention of qualified non-physician clinical staff, presumably including sonographers. And it's an open question as to how all of this financial pressure will affect the salaries of cardiologists that have sold their practices to hospitals. The major additional change that is on the horizon for hospitals, and one that will directly affect the provision of echocardiography, relates to the level playing field proposal that has been floated by MedPAC. MedPAC is an advisory committee that advises Congress as to legislation that it might want to consider, especially legislation to save money. And MedPAC has proposed formally recommended now that hospital outpatient payments for certain APCs, or ambulatory payment classifications, be reduced to the levels that are paid in physician's office practices, that is, the technical component of physician office practice, echo, for example. One of the options that MedPAC has specifically recommended is that this be done for cardiovascular imaging services. The focus here is on echocardiography as well as nuclear cardiology, but the primary focus is on echocardiography. About a third of the savings that MedPAC projects for this kind of level the playing field policy would actually come from echocardiography. So the question then is, will Congress enact legislation that levels the playing field between physician's office and hospital outpatient payment for echo services? And echocardiography really does have more to lose than any other cardiovascular imaging service if that were to be done. The next major issue that's in play on the Hill at this point is physician self-referral. Diagnostic imaging, including echo, are still perceived to be overutilized, even though the absolute trend lines for all diagnostic imaging, including echocardiography, are either decreasing or stable. The President's budget last year included a proposal to eliminate office-based advanced imaging and office-based laboratory and a number of other services. There has been an aggressive lobbying campaign by opponents of physician ownership, including independent diagnostic testing facilities, independent clinical laboratories, physical therapists, and others, to cut back on physician self-referral. And Congress is currently considering eliminating the ability of physicians' offices to provide advanced diagnostic imaging. I should emphasize that advanced diagnostic imaging is not echo. The reason that we are concerned about this is that once they eliminate the ability of physicians' offices to provide other types of imaging, we are very concerned that the eye of Zoron, as Dr. Bird would say, will turn to echocardiography and other ultrasound services, and that we'd be next. What about the appropriate use criteria? The professional community has long espoused the use of appropriate use criteria as an alternative to eliminating physician's office diagnostic imaging. And in fact, the SGR proposal, which is currently under consideration in Congress, includes a provision that would mandate the use of appropriate use criteria for advanced imaging and mandate the use of pre-approval, actually, for those referring physicians that are considered outliers, that is, that order, quote, quote, too many advanced imaging services. This proposal actually did originally include echocardiography, so that it would have mandated the use of appropriate use criteria for all echo, and what was more concerning to us, would have required pre-approval for outliers. The statute does not really define how outliers are defined, but we are very concerned, we were very concerned that the term would be defined in a way that would focus on those providers who provide a lot of echocardiography services, regardless of whether they're appropriate or not. So as a result of some fairly aggressive lobbying that was done on behalf of the American Society of Echocardiography by our lobbyists, echocardiography was actually removed from this provision of the SGR replace bill. Another challenge that we face has to do with hospital outpatient packaging. This was something of a surprise that emerged last year in the Notice of Proposed Rulemaking for the Hospital Outpatient Prospective Payment System. CMS proposed to package payment for our primary CPT code, that is 93306, when it's performed on the same date of service as another significant procedure. Under this proposal, if a TTE with spectral and color Doppler were performed on the same date of service as a clinic visit or an emergency room visit, or for that matter, a SPECT procedure, there would be no separate payment for the echocardiogram. This was a proposal last year. We successfully fought it so that the final rule does not include this provision. All echocardiograms in hospital outpatient departments remain separately payable at this time. However, in the final rule, CMS indicated that it does not consider this battle to be over and that it is likely to return to future bundling proposals, and we really need to be careful that those proposals do not adversely impact major procedures like echo. There are a number of other challenges that are on the horizon. TEE is undergoing reevaluation, and these days, when a CPT code undergoes reevaluation, it's very rarely experiences an increase in payment. There is also a review of all ultrasound costs, which could adversely impact us and take away the gains in payment that we have for technical component of echo this year. And we really need to be on the lookout for a further expansion of what's called the multiple procedure payment reduction, which reduces payment for the second and subsequent service that's provided on the same date. So, for example, if there are two echoes performed on the same date, or a vascular and an echo performed on the same date, or a SPECT and an echo performed on the same date, the second of the procedures payment is reduced by 25%. So, as I indicated, a number of the challenges that we have are being considered on the Hill right now. Many of these are being considered in the context of the SGR reform and replace bill. That bill would consolidate the current PQRS, electronic health records, value-based modifier, and other programs into a new program, and it would basically freeze updates through 2023. And after that, there would be more minimal updates for physicians outside of an advanced alternative payment model, which is sort of like an ACO. Other trends, we're going to see increased experimentation with ACOs and other types of alternative payment methods. We're going to continue to see an increase in performance, efficiency, and quality measurements. We're going to see an increase in the profiling of physicians for quality and resource utilization. And unfortunately, I think we're going to see increasingly fee-for-service payment cuts to try to encourage folks to get into employment arrangements or ACO arrangements, which have less of an incentive for overutilization. These are a number of the new pilots and demos, including ACOs. There is a bundling project that deals with post-acute care, value-based modifiers, medical homes, and many of these are being run out of the Center for Medicare and Medicaid Innovation. So we're looking at overall more administrative burdens, increased emphasis on a team approach and coordination of care, and increased emphasis on cost containment through bundling of payments and capitation models rather than fee-for-service. I think what will the impact be on physician practices? I think we're going to continue to see smaller practices disadvantaged unless they affiliate with hospitals or larger groups to achieve economies of scale. And many of these reforms favor primary care with the medical specialties needing to prove their worth as efficient providers, for example, by keeping patients healthy or out of the emergency room, or by reducing readmissions to hospitals. ASE has been very, very active, as you can tell, over the past year in fighting hospital outpatient bundling and getting echo out of the provisions that would have mandated pre-approval for Medicare patients, for outliers, and in many other ways. Our advocacy efforts are very ably headed by Irene Butler and by our lobbyist, Peggy Tai, and I participate as well. We urge you to continue to pay attention to our advocacy alerts. We need your help. A lot of these proposals remain pending in Congress, and we hope that you will be able to and willing to support our efforts by reaching out to your congresspeople as we call upon you for assistance. I'd like to now turn this podium over to Judy Rosenbloom.
Good afternoon, everybody. I'm glad to be here. Thank you, Diane. That was pretty impressive. It really goes to show how much work is being done behind the scenes that many of us don't know. And I'm going to move into now a discussion about, from the practical point of view, most of you who are on the call are actually involved in coding and payment and reimbursement and dealing with all the issues that come forward. And hopefully we can walk through this and clarify some of the frequently asked questions and just try to put some sense to some of this information. So really, the most important piece when you think about coding and billing is the whole idea of putting the clinical care, what the clinical circumstance is, and marrying it to the selection of the code and where ultimately it will get billed. And so the documentation, how the physician documents, both the ordering physician as well as the interpreting physician, that documentation becomes the entire story. It reflects, it helps the billers and the coders be able to select the correct code as to what was done. And it also goes back to when the if a claim is being denied, the coders go back into the documentation and they look at the story and they figure that out. So the documentation becomes the first piece, the hierarchy that everybody looks at and must tell the story. And so really just keep it simple. Make sure you reflect what was done, why, and the findings. Be specific about it. And always have a separate written interpretation report. It's not enough to put into the chart echo done. And there should always be study archival for subsequent review. Specifically, the report should identify all elements of the procedure, and even there should be an interpretation for 2D, color, Doppler, 3D if done, contrast, saline, whatever it might be. It should be singled out to ensure that the coder knows those pieces were actually done. Do report all measurements. And what's very important, too, because in the CPT manual, it states that they want to know what anatomy, they want to know all of the anatomy, and I'll get into that in a minute. But if views were attempted, and they could not be visualized, that should be stated in the report because it demonstrates the work was actually done, but a technical reason wouldn't allow it to be reported. In addition, note in the report if a different procedure is required. So, for example, if the transthoracic echo was not, the information wasn't diagnostic enough and a TEE is recommended, that should be in the transthoracic report. So let's talk about coding. There are two different types of code sets. One is the diagnosis codes, which are currently reported as ICD-9, and then there are the procedure codes, which are the CPT codes, and the HCPCS codes, which are supply codes, or the contrast for your purposes. The ICD-9 diagnosis codes actually define medical necessity. It tells the insurance company, or it goes on the claim form as what is the reason for the exam, what are the signs and symptoms, what is the diagnosis. The CPT codes are used to report the physician work and the procedures associated with it, as well as hospitals also report it to demonstrate the procedures that were done in the hospital outpatient setting. There's also an opportunity to attach different modifiers depending upon if the routine procedure has changed. Many of you are familiar with that -26, which identifies that only the interpretation was done, or a -TC if done in the office. That's the technical component, and you're only reporting the technical component.
As I said before, strong documentation will support coding compliance. And some of the important tips from you as sonographers or physicians who are actually doing the coding is really code any documented, confirmed, or definitive diagnosis from the report. What do I mean by that? If you can make the statement there is mitral stenosis or mitral regurg or whatever it might be, if there's something definitive, that gets coded. If you cannot, if it's more or less that there are just certain observations being made, then select codes that describe the patient's signs or symptoms if there isn't a definitive diagnosis. So just keep in mind, if the report is definitive, that's what gets coded first. And if it's not definitive, report the signs and symptoms of the patient. In addition, there are also V codes. And so hopefully you do have that list of V codes. And they are very good to describe circumstances other than disease or injury. For example, preoperative exams or complications from chemotherapy, things like that. Those codes become very important because, again, it rounds out the story. Just to let you all know, I'm sure you've been hearing this within all of your institutions, ICD-10 codes will become effective on October 1st, 2014, and ICD-9 codes will no longer be used. I assume that most of you are going through some sort of introduction or training from your facilities. If not yet, it will be shortly, and ASE will also at some point start discussing those codes as well. Next slide, please. Okay, so some of the things, when I talked about coding from the report, I just wanted to give you some examples here. So this is an example of when the order for the transthoracic echo states murmur. The findings of the echo confirm mitral regurg, and so you can code for the mitral regurg, and this is, as you can see, that's the definition of the different codes. Next slide. This is reporting signs and symptoms with an underlying existing condition. So a patient has insulin-dependent diabetes and complains of chest pain when exercising. A stress echo is ordered, and the results are normal. So you code the chest pain as the primary diagnosis because it's the acute problem. It's why the patient showed up for the echo. But the diabetes is the secondary problem, and therefore it supports the need for the echo because there is an underlying disease that demonstrates there could be some cardiac-related issue for chest pain, and therefore that kind of claim should get paid or should get accepted. Slide 8. This is reporting clinical circumstances not cardiac-related. So a patient who has completed a round of chemotherapy requires the echo for evaluation of possible cardiotoxicity. And as you can see, what I discussed before, there's a V code. There's a couple of different ones. This particular one is the follow-up exam following chemotherapy. So again, it supports the order for the echo, even though it's not necessarily a cardiac-related disease. The next slide, 9, reporting a rule-out diagnosis. The order is for rule-out mitral valve prolapse. The patient reports shortness of breath and chest pain, and the results are normal. So this is a perfect example of where you code the patient's symptoms rather than a rule-out or a diagnosis of mitral valve prolapse, because you certainly don't want to give that patient a diagnosis when it's not appropriate. So again, code the patient's symptoms when it's not clear, when there isn't a definitive diagnosis. Let's move on to slide 10, and we're going to move on to the CPT codes. Now remember, CPT codes report the actual procedure, and this is a very common question that I get asked: what elements are included in a complete echo? And the codes for a complete echo are 93303, 07, 06. It actually 07, yes, 07 and 06. Per CPT book, this is how it's written in the book. Multiple 2D views of all the chambers, the valves, the pericardium, and portions of the aorta with appropriate measurements. And the point that they're making is that every chamber and every valve should be reviewed, and that makes a complete echo. But the inability to visualize or measure all of those components is that there may be, you may not be able to do that. And so if you just document in the report that the attempt was made, if the report is reviewed, then you'd be able to validate that this was a complete echo. CPT does not describe any kind of requirements associated with Doppler or color. So once again, it's reliant on how thorough the report is. If you were to be audited and the report was to be reviewed, the debate or the argument would be, was this a complete Doppler or was it not? And the documentation would identify or you'd be able to help support your argument that it was. Moving on to slide 11. So then the question becomes, what is a limited or a follow-up transthoracic echo? And 93304 is the congenital limited, and 93308 is the non-congenital. And it's defined by the CPT manual as an examination that does not evaluate all the structures that comprise of a complete echo. Pretty interesting definition. So basically, it's thought of as a focused clinical question or a follow-up to a prior study. And going back to the point of, if it's not documented that you try to visualize all of the anatomy, it may be assumed that it's a limited echo. Therefore, because they understand that a limited echo is not evaluation of all the structures. Hope that made sense. Moving on to slide 12. What procedure codes can be reported with Doppler and color? There are 3 categories of procedure codes: TEE, stress echo, and congenital TTE. And Doppler and color Doppler cannot be separately reported with the bundle TTE code, the 93306, and it cannot be reported with 93307. So it's very clear the CPT manual states it specifically, and there really isn't too much argument by it's very clear. The instructions are very clear about that. Next slide, 13. Can a transthoracic echo routinely be billed at the same time with a stress echo? One of the biggest questions I always get asked, and the answer is no. The stress echo code was created with an understanding that there would be a basic transthoracic echo within the stress echo code, and as a routine exam, they should not be reported together. Next slide, 14. What is the difference between stress echo codes 93351 and 93350? This is also a common question, one in which I dislike answering because it's very confusing, but we'll give it a shot. Physicians report 93351 when the same physician provides all the components of a stress echo, and that means the stress echo itself, the stress testing, the interpretation, the review, and the report, the supervision, etc. When one physician does all the components, 93351 is reported. The hospital also reports 93351 when both the stress echo and the stress test are also performed. And the AHA coding clinic, which is the American Hospital Association Coding Clinic, which is considered an authority on these types of coding questions, they have given guidance that 93351 is the applicable code to report, regardless if the stress test and the stress echo is done in different departments. 93350 is only used by physicians when the stress echo and the stress test components get separated because of different physicians. And so that opportunity arises when one physician is doing the stress echo and another physician may be doing the interpretation of the stress test. And those, you can see the different components that get reported. There's 93016 for just the physician supervision, the EKG component, technical component, 93017, and the physician interpretation and report, 93018. And you can see in the example that it would be 93016 plus 93018 plus 93350 if physician B does those components, just does those components. Moving on to slide 15, how is saline echo reported? And there isn't a specific echo administration CPT code for saline. It's reported by the facility, the one who's using the drug. They can use any of the drug codes, associated with saline, but it is reported by the usual primary echo service, 93306, 5051 for stress echo, or for TEE as well. Slide 16, contrast stress echo. Every time a stress echo is done, it is report the primary echo procedure. In addition, report the supply of the contrast agent. This is both for the physician office setting as well as the hospital outpatient setting. It is very important that the agents get reported for proper rate setting. They're in the hospital outpatient setting. The hospital will not get a separate payment for the agent, but it is calculated into the payment methodology, and therefore it must be reported to demonstrate the resource was used. In the physician office, the contrast agent will get paid. Usually it's invoice price plus 6% average selling price. Slide 17. Oh, I guess I jumped ahead. But in addition, in the physician office, there is an additional code that can get reported with the primary echo procedure, and that is 93352 if you're doing stress echo. 93352 describes the administration of the contrast agent. For a stress echo, it is not a code that is allowed or gets separately paid in the hospital outpatient setting. In the hospital outpatient setting, contrast stress echo has its own set of codes. Basically, Medicare set up a series of what we call C codes that describe all echocardiography procedures, similar to the CPT codes, except they have assigned them with a C. And that's very important that those codes are reported with the contrast agents as well. So an example here is C8928, which is a transthoracic echo. You can see with contrast or without contrast. It follows the same coding structure as the CPT codes. The next slide, 19, is there reimbursement for 3D? And the answer is it depends. Medicare coverage and private payer coverage is not a one-size-fits-all. And payers have set different policies for different types of procedures. there are very few policies that discuss 3D in any kind of great detail. And since the 3D code is a mixture, is a conglomerate of CT, MRI, ultrasound, any type of tomographic procedure, it gets a little bit confusing. Most of the time, 3D is thought about in terms of CT and MRI. And so the coding policies that are out there usually reference some type of radiology procedure. However, the correct code for echo is the 3D, the 76376 or 76377. Those codes get added to the primary procedure and are allowed in many circumstances by many payers. I'm showing here now a sample local Medicare policy that actually demonstrates that they want to see as a secondary diagnosis one of those specific ICD-9 diagnosis codes. And I've highlighted the one that would be appropriate for echo. This is a typical policy that we have seen at different Medicare payers. It may or may not work with private payers or with other Medicare contractors who don't even have policies. But what it actually points to is the fact that you can actually put a secondary diagnosis to show that there is some type of abnormal finding on some other exam, and that is for the intrathoracic organ, demonstrating that there is a medical necessity need for the 3D. The primary diagnosis, again, would have to be cardiac related, and the documentation, should the claim be denied, would want to demonstrate what the need was for that 3D exam. In addition, I would recommend that if your claims are being denied, that you refer to the 3D position paper from ASE. I've given here the link to that paper that demonstrates the medical necessity, the reason that 3D is well accepted. And that helps to support your argument for that particular claim. Moving on to slide 12. What's on the horizon for CPT? The ASE, the American College of Cardiology, and SCAI have been collaborating over the past year in the development of a proposal for a new CPT code that will describe the performance of TEE during interventional cardiac procedures. The application is being considered at this upcoming February meeting next week for CPT. And if the application is approved, it could become effective January 1st, 2016. So stay tuned. I'm sure you will hear more about this as we go through the process. Slide 21. This is just, I want to give some samples of what the payments are, the difference between the physician and the hospital. Diane has talked a great deal about the distinctions in those payments. And so as you can see, our bundle payment, our bundle code 93306 in the physician office setting, globally is paid at a national level, is paid $229. In the office setting, that is an increase of 21% from last year. For once, we can say that with a smile on our face. You can see in the hospital setting, the 93306 has been increased as well to $427. Moving on to slide 22, the congenital codes as well have seen an increase in both the hospital and the physician areas. And I'm looking at the time. I want to be mindful of the time so we can get the questions. So I'll just go through these very fast. Slide 23 is stress echo. You can see in the office setting, it's $282 for the global payment, and in the hospital setting, it is $594. Here we have on slide 24 the carotid duplex. In the hospital setting, it is $192. There is a decrease for the carotid duplex studies for this year. And in the hospital setting, there was an increase. You can see it as $191. I think I'm going to just, moving on to slide 25. It's becoming more and more apparent, we are seeing this more and more, that the payers have instituted some form of being able to restrict the qualifications, who does echo, who does vascular, what the qualifications may be. They're trying to restrict utilization. And it's very complicated to be able to track and follow all of these different policies that payers have come up. First, there are multiple payers, but second, payers actually hire radiology benefit managers to implement these programs. And so it's not always transparent as to what these programs are. And this is actually a very big example, a very good example of where the Echo Lab needs to start to have more and more conversations with the billing departments. The billing departments receive notifications from their various payers. They get network bulletins on a monthly or quarterly basis, or they may even get a specific notification that identifies what the new policies may be, if prior authorization is necessary, if physicians need to be privileged or credentialed as an NBE, if sonographers need to have certification, if accreditation is mandatory. All of those elements are actually sent out to the billing offices. And if the Echo Labs don't receive that information, then obviously you are operating without knowing all the information, and you may not be getting paid, or the billing department may not know that you are eligible to be paid or reimbursed. And so this is just a depiction of what some of the examples are of the different radiology benefit managers and the various payers that they work for to institute these policies. You can see CareCorps National works with Aetna, GHI, Horizon, and they actually mandates mandatory echo accreditation. AIM works with Anthem, which is one of the larger national payers across the country, and you can see again prior authorization is necessary. And without going through all of these details, the whole point is that, in my opinion, the Echo Lab really needs to pay attention to being accredited. Physicians' qualifications need to be looked at to ensure that they are at some level and can document their level of qualifications. And sonographers' certification is clearly a necessity as well to be able to, if more policies come into place, then you will be able to get reimbursed by the payers. So having said all of that, I just want to remind you that ASE offers an exclusive member service to have access to coding consultant myself to be able to answer your questions. And if you are a member, you can access that information from the website address. And with that, I'll open up the questions.
The first question has to do with stress testing, with supervision. Where does the physician need to be in the room, in the suite? I believe, although I'm not certain, that stress testing is a direct supervision test, which means that the physician needs to be in the office suite. Judy, is that your impression as well?
Yeah, it is direct supervision, so they need to be in the suite.
The second question is, when performing an echocardiogram for congenital heart defects, we use these codes 93303, 20, and 25. If the study reveals a normal cardiac structure, does the code have to be changed to a 93306?
According to CPT, it does have to be changed to 93306. If the result is normal, then 93306 is the appropriate code. That is something that could theoretically be challenged if you felt up to it, if a payer was to audit, depending upon your documentation. But the rules of coding state that if a exam is normal, it goes to a non-congenital code.
The third question, there's also the new code 93351 for a stress echo is paying a lot less than the older 3 codes we used to bill. Can we use any other code?
The rules of coding state that you cannot unbundle. It is one of the reasons why the bundled code was created, because the bottom line is that 93351 cannot be unbundled to the other codes if the same physician is performing all of the testing.
Similar question, why does the new bundled code 93306 pay much less than the old code with 0720 and 25? Basically, the revaluation resulted in that reduction. It was quite deliberate, and why they did that is, I suppose, a question. My own view is that they wanted to just save money on echocardiography because there was no reason why the value shouldn't have been the sum of those 3 prior values. But they took some time away because all 3 procedures are being performed at the same time. So, unfortunately, we lost money on that reevaluation.
Right. I would also just add that at this point, 93320 and 25 cannot be reported to 93307, so it's an exercise in futility to compare.
Number 5 is they perform a pediatric echo study for a child with a murmur, but is there a way to bill for the congenital study performed as the 93303, 93320, and even if the final diagnosis is only a murmur and no heart defect was detected?
Right. Again, that's similar to the other question. If a exam results in a non-congenital diagnosis or condition, then the non-congenital code must be reported.
Question 7 is, will physicians' offices still be able to perform diagnostic imaging if they are owned by a hospital? First of all, there has been no change in current law at this time, so I am assuming that this question relates to what if the in-office ancillary services exception is limited and advanced imaging can't be performed by physicians' offices. That would not affect hospital-owned labs. There's still some hoops that hospital-owned labs have to jump through, but that legislative proposal does not affect hospital labs. Are vascular tests also being scrutinized in the same way as echo? I would say that vascular tests are sort of in the next line of scrutiny, and I would think that at least physician's office vascular tests will be affected if CMS proceeds to reduce the ultrasound equipment input, which is now considering. Let's see. Number 9. Please review outpatient stress echo coding Doppler add-on use of modifier 59. I think that's yours, Judy.
Say it again. I don't think I caught it.
It says, please review outpatient stress echo coding Doppler add-on, question mark, use of modifier 59, question mark.
93351 stress echo would be reported by the hospital. The Doppler codes 93320 and 93325, or even the limited Doppler code 93321, can be added. Modifier 59 is not necessary to and should not be appended for any reporting of the Doppler codes in addition to the stress echo. So I think that answers it.
Next question. If a bubble study is done, can you bill for the saline in a hospital setting for inpatient and or outpatient? I think that was reviewed in the presentation.
Right. There, you can bill for the agent of the saline, but there is not any different, just bill for the primary echo code.
Where do we stand on reimbursement prior approval and indications for 3D code 76376 for both TTE and TEE?
I have not seen any policies that require prior authorization for 3D. However, since many payers require prior authorization for echo and stress echo, it would probably fall under that. It would be probably a good idea if you're working with a payer that requires prior authorization to get 3D authorized as well.
Okay, D codes are not being accepted by Medicaid in Pennsylvania, e.g. B17.49 for family history of heart defects for fetal echo. Any thoughts? I have none.
What was the V code again?
The B code is for family history of heart defects for a fetal echo.
I think that's a very specific type of issue because there may be a question about medical necessity, if that is allowed or not. So my recommendation would be, if that's one particular place, that you actually have to contact and work with the Medicaid medical director to have a conversation about that issue and be able to support the need for the echo. And if you want further information, I would recommend that you contact me through the ASE website, and maybe we can work specifically towards that, so I can understand that better.
Question 13, if a patient's script states murmur, can you use MR to bill after the fact?
I'm sorry, Diane, can you read that again?
If a patient, question go. If a patient's script states murmur, can you use MR to bill after the fact?
If the MR is noted on the report, then you can absolutely bill for MR, if I'm understanding the question correctly.
I'm assuming that means that the MR was actually ordered. So you need, at least for Medicare purposes, you need an order for the MR. It's not that you just do it because it states murmur.
Oh, I misunderstood. I thought we were talking about the diagnosis of MR.
Oh, I don't know. Not sure I understand.
Okay. Yeah. If that person wants to write in again that question, since we're confused as to what the question is, please do so.
I thank you, everyone. On behalf of ASE, I would like to especially thank Diane Millman and Judy Rosenbloom for their presentation this afternoon, and also a special thanks to everyone who took the time to join us for the webinar. I do apologize for the slight technical difficulties we had with the power outage, but I'm glad it was able to, work out with the slides presented by Nick. And this concludes today's webinar. If you would kindly leave your web browsers open, you'll be redirected to complete your evaluation for the webinar. In addition, if you're interested in getting the answers to the questions that were on this page, we will be posting them on the practice management website along with a recording of the webinar. Thank you and have a wonderful evening.